Our today's discussion is about gastrointestinal diseases and its nutritional management. Let's start with digestive process. When food is taken into the mouth, the act of eating stimulates the GIT tract into accelerated action. Throughout the digestive process, highly coordinated systems and interactive functions respond. Secretory functions provide the necessary environment and agents for chemical digestion. Peristalsis and gravity move the food mass along. Nutrients are absorbed into circulation and carried to cells that take up what is needed to nourish the body. Emotional factors influences the overall individual response pattern. This highly individual and interrelated functional network forms the basis for nutrition therapy in disease. After food is taken into the mouth and masticated, which forms a bolus, swallowing occurs, allowing the bolus to pass from the laryngopharynx into the esophagus entrance at the upper esophageal sphincter. Food is pushed through the esophagus by gravity and involuntary muscular movements called peristalsis, controlled by the medulla oblongata. Circular muscle fibers contract, constricting the esophageal wall, squeezing the bolus towards the stomach. The lower esophageal sphincter muscle at the entry to the stomach forms a controlling valve, relaxing to receive the bolus and then closing to hold each bolus for some initial digestive actions of enzyme. Stomach cells produce enzymes to partially break down food particles and other secretions to protect themselves from being broken down. Passage of food from mouth to stomach takes about 4 to 8 seconds. Chyme is released by the stomach through the pyloric sphincter into the duodenum, the first section of the small intestine where most digestion occurs. A number of small intestine and accessory organ conditions may interfere with normal food passage and digestive processes and create malabsorption problems. These overall conditions vary widely from brief period of functional discomfort to serious disease and complete obstructions in making nutrition therapy recommendations for food choices and feeding modes. The dietetics practitioners will take into account the degree of dysfunction. Teeth and jaw muscles in the mouth work together to break down foods into a form that can be easily swallowed. Conditions that interfere with this process interfere with nutritional intake. Tissues of the mouth often reflect a person's basic nutritional status. In malnutrition, tissues of the mouth deteriorate and become inflamed and are more vulnerable to local infection or injury. causing pain and difficulty with eating. These conditions in the oral cavity include gingivitis, which is the inflammation of the gums, involving the mucous membrane with its supporting fibrous tissues circling the base of the teeth. Second one is stomatitis, which is the inflammation of the oral mucosa lining the mouth. And third one is glossitis, inflammation of the tongue, ankylosis, a cracking and dry scaling process at the corners of the mouth, affecting the lips and corner angles, making opening the mouth to receive food difficult. These oral tissue problems may also be non-specific and unrelated to nutritional factors. In some cases, gingivitis and stomatitis occurs in mild form in relation to an other disease or stress. A severe form of acute necrotizing ulcerative gingivitis occurs. It is caused by a specific infectious bacterium, Fusobacterium nucleatum, in conjunction with the spiroside Treponema vinciti. It is also known as Vincent's disease, from the Paris physicians Henry Vincent, who first identified the disease process. Gums around the bases of the teeth become puffy, shiny, and tender, overlapping the teeth margins. Affected gums often bleed, especially during toothbrushing. This serious condition destroys gum tissues and supporting tissues of the teeth and requires a course of antibiotic treatment. Mouth pain in these conditions often cause decreased food intake. Maintaining adequate nutritional intake then becomes a major problem. Patients are given high protein, high energy liquids and then soft foods, usually non acidic and without strong spices so as to avoid irritation. Temperature extremes may also be avoided if they cause pain. Gradually, foods are increased according to toleration, and foods are often supplemented with vitamins and minerals. In severe disease, use of a mouthwash containing a mild topical local anesthetic before meals help relieve the pains of eating. The incidence of dental caries has recently been reduced in children and young adults. It is still present in many children and older adults, especially those unable to afford regular dental care, and causes tooth loss and chewing problems. In older adults, periodontal disease is a major cause of loss. If dental caries is untreated or if dental hygiene is poor, then gum tissues at the base of the teeth becomes damaged and pockets from between the gums and the teeth. Dental plaque forms from a sticky deposit of mucus, food particles and bacteria. Plaque hardens into calculus, a mineralized coating developed from plaque and saliva. These hardened particles then collect in pocket openings at the base of the teeth where bacteria attack periodontal tissues. The result is bacterial erosions of the bone tissues, surrounding affected teeth and subsequent tooth loss. Preventive care through daily dental care with fluoridated toothpaste, careful flossing, and periodic plaque removal by a dental professional forms the best approach. Extensive tooth loss leads to the need for tooth replacement with dentures. In many older adults, these dentures become ill-fitting, especially when weight loss occurs and hinder adequate chewing. All of these dental problems need to be reviewed as part of the physical assessment in any patient's nutrition history so that food texture and forms can be adjusted to individuals' need. Disorders of the salivary glands affect eating because saliva carries an amylase that begins starch breakdown and is vital in moistening the foods to facilitate chewing. Problems may arise from infection, such as infection with the mumps virus that attacks the parotid gland. Other problems come from excessive salivation, which occurs in numerous disorders affecting the nervous system, such as Parkinson's disease, and from local disorders such as mouth infections or injury. Problem may arise from any disease or drug that causes overactivity of the parasympathetic division of the autonomic nervous systems, which controls the salivary gland. Lack of salivation, which causes xerostomia, which is the dry mouth, condition of dry mouth, may be a temporary condition caused by fear, salivary gland infection, or action of anticholinergic drugs that hinder the normal action of neurotransmitters. Clients with dry mouth best tolerate moist, soft foods with added gravies and sauces. Permanent xerostomia is rare, but does occur in Sjogren's syndrome, a symptoms complex of unknown cause thought to be an abnormal immune response. It occurs in middle-aged or older women and is marked by dry mouth and enlargement of the parotid glands. It is often associated with the rheumatoid arthritis or radiation therapy. Difficulty occurs in swallowing and speaking. Problems also include tooth decay and interference with taste. Salty foods dry the mouth and should be avoided. Chewing gum or sucking on sugarless candy can increase the saliva secretion. Extreme mouth dryness may be partially relieved by spraying the inside of the mouth with an artificial saliva solutions. Most people take swallowing for granted. Each day we eat, chew, and swallow without giving it a second thought. The process of swallowing involves highly integrated actions of mouth, pharynx, and esophagus. Swallowing difficulty, known medically as dysphagia, is a fairly common problem arising from many causes, including stroke, aging, developmental disabilities, and nervous system diseases. It may be only temporary, such as a piece of food lodged in the back of the throat for which the abdominal thrust is appropriate first aid, or it may be involved with insufficient production of saliva and xerostomia. Such dysfunctional swelling causes individuals to aspirate food particles, in turn causing coughing and choking episodes. Dysphagia is of concern for many reasons. Foods may enter the trachea and aspirate into the lungs, allowing bacteria to multiply, leading to pneumonia. Clients with dysphagia are usually referred to a special interdisciplinary team that includes a physician, speech pathologist, nurse, clinical dietitian, physical therapist, and an occupational therapist with special training in the swallowing problems. Thin liquids are the most difficult food from to swallow. Depending on the level of dysphagia, liquids may need to be thickened. Thickening agents include baby rice, commercially prepared thickeners, potato flakes, and mashed potatoes. Level of thickness include thick yogurt or pudding consistency and medium thick nectar consistency. Esophagus is a long, muscular tube lined with mucous membrane that extends from the pharynx or throat to the stomach. It is bounded on both ends by circular muscles or sphincters that act as valves to control the food passage. The upper sphincter remains closed except during swelling, thus preventing airflow into the esophagus and stomach. Disorders along the tube that may disturb normal swelling and food passage include esophageal spasm, which is the uncoordinated contraction of the esophagus, and esophageal stricture, which is a narrowing caused by a scar from previous inflammation, ingestion of caustic chemicals, or a tumor, and esophagitis, which is an inflammation. These problems hinder eating and require medical attention through dilation, stretching procedures, or surgery to widen the tube or drug therapy. Defects in the operation of LES muscles may come from changes in smooth muscles itself or from nerve muscles hormonal control. These LES problems arise from spasm, stricture, or incompetence. In eclasia, if the LES does not relax normally when presented with food during swallowing, the uncommon condition of eclasia, which is a meaning without and chalasia meaning relaxation. A primary esophageal motility ailment, eclasia is characterized by absence of esophageal peristalsis and failure of the LES to relax on swelling. These aberrations bring about a functional obstruction at the gastroesophageal junction. Signs and symptoms characterizing eclasia are dysphagia, regurgitation, chest pain, heartburn, and weight loss. The exact cause of eclasia is unknown, but it is thought to be an autoimmune disorder, infectious agent, or both. Nutritional requirement of the patient with the eclasia vary with severity of the disease and approach to treatment. generally nutrient-dense liquids and semi-solid foods, taken at moderate temperature in small quantities and at frequent intervals are usually tolerated by a patient with achalasia. Pharmacologic calcium channel blockers, nitrates, phosphodiesterase inhibitors. This intervention is used to reduce LES pressure and is of limited value, and mechanical dilation by pneumatic balloons. This intervention involves esophageal dilation to decrease LES pressure. It is successful in decreasing LES pressure in 42% to 85% botulism toxins. This intervention decreases the LES pressure by blocking the release of neurotransmitters at presynaptic cholinergic nerve ending. The best results have been seen in the patients with vigorous achalasia. Effective duration of the treatment varies but takes 6 to 11 months in most patients. Esophageal myotomy. This intervention surgery is considered to be the primary treatment. The procedure involves controlled division of muscle fibers of the lower esophagus and proximal stomach, followed by a partial fundoplication to prevent the refluxes. It reveals the symptoms in 80% to 100% patients. Gastroesophageal reflux disease, which is the backflow or regurgitation of gastric contents from the stomach into the esophagus, is a very common disease. Regurgitation of the acid gastric contents into the lower part of the esophagus creates constant tissue irritation because the wall of the esophagus is not protected from the acid of the stomach. During reflux, many patients feel a burning sensation behind the sternum that radiates towards the mouth, producing the most common symptoms of GERD: heartburn, which is unrelated to disease of the heart. Additional symptoms of GERD include acid indigestion and regurgitation, which often have a negative effect on quality of life. Other less common symptoms include iron deficiency anemia with chronic bleeding and aspiration, which may cause cough, dyspnea, or pneumonitis. Sometimes substernal pain radiates into the neck and jaw or down the arms. Acid reflux may be worsened by a hiatal hernia, pregnancy, obesity, pernicious vomiting, or nasogastric tubes. A number of drugs also lower LDS pressure, causing GERD and heartburn to be a side effects of drugs used in the treatment of other conditions. Acid and pepsin cause tissue erosions with symptoms of substernal burning, cramping, pressure sensation, or severe pain. Symptoms are aggravated by laying down or any increase of abdominal pressure, such as that caused by tight clothing. This condition is related to a non functioning gastroesophageal sphincter, frequency, and duration of the acid reflux, and inability of the esophagus to produce normal secondary peristaltic waves to prevent the prolonged contact of the mucosa with the acid pepsin. A hiatal hernia may or may not be present. The most common complications of GERD are stenosis and esophageal refluxes. What is the treatment of gastroesophageal reflux disease stages? There are several categories. First category is mild heartburn, only associated boots for less than 1 week, and recommended treatments include early low fat dinners, elevation of head of bed, antagonistic less than 6 weeks, and alkali antacids single dose PPIs less than 6 weeks. And second one is the moderately severe heartburn or poor response to receptor antagonist. PPI's single dose less than 6 weeks is the recommended treatments. Recurrence and the persistence of the moderately severe GERD symptoms and the recommended treatments include gastroenterology, endoscopy, and biopsy of the esophageal gastric junction for the Barrett's metaplasis. Recurrent causes of the PPI's therapy. Other categories severe persistence GERD symptoms. Its treatment is continuous PPI's therapy, often 2 capsules per day. And other category is recalcitrant GERD symptoms. Its recommended treatment includes maximal PP1 therapy. Treatment of GERD is aimed at one or more aspects that cause or continuous symptoms. Nutrition therapy plays only a minor role in the management of GERD, and none of the dietary measures can be classified as evidence based treatment. Hiatal hernia is another situation of gastroesophageal. The esophageal normally enters the chest cavity at the hiatus and opening in the diaphragm membrane and immediately joins the upper portion of the stomach. A hiatal hernia occurs when a portion of the upper part of the stomach at this entry point of the esophagus products through the hiatus alongside the lower portion of the esophagus. Food is easily held in these herniated areas of the stomach and mixed with acid and pepsin. It is regurgitated back up into the lower part of the esophagus. Gastritis can occur in this herniated portion of the stomach and cause bleeding and anemia. Reflux of gastric acid contents cause symptoms similar to those described. A regular diet of choice using the frequent small feedings for comfort is usually tolerated. Obesity is often associated with hiatal hernia. Weight reduction is a primary goal. Avoid tight clothing to help relieve discomfort. Patients will need to avoid leaning over or lying down immediately after meals and should sleep with the head of the bed elevated. Antacids help relieve the burning sensation. Large hiatal hernias or similar sliding hernias may require surgical repair. Stomach and duodenum include peptic ulcer. An ulcer is the loss of tissues on the surface of the mucosa. In the GIT tract, an ulcer extends through mucosa, submucosa, and often into the muscle layer. Peptic ulcer is the journal term for an eroded mucosal lesions in the central portions of the GIT tract. A peptic ulcer can occur in any area of the stomach exposed to pepsin. Areas affected include the lower portion of the esophagus, stomach, and first portion of the duodenum, called the duodenal bulb. Esophageal and gastric ulcers are less common. Most ulcers occur in the duodenal bulb, where gastric contents emptying into the duodenum through the pyloric valve are most concentrated. Gastric ulcers occur usually along the lesser curvature of the stomach. Peptic ulcer disease is a benign disease, but ulcers do tend to recur. Gastric ulcers are more prone to develop into the malignant disease. Weight loss is common in patients with gastric ulcers. Patients with duodenal ulcers may gain weight from frequent eating to contract pain. Peptic ulcer is caused by Helicobacter pylori in the stomach or intake of non-steroidal anti-inflammatory drugs. Nutrition or diet is not thought to play a significant role in the cause. Helicobacter pylori is a short, spiral-shaped, microcephalic, gram-negative bacillus that attach itself to the gastric mucosa. It is able to survive the acidic environment of the stomach by secreting enzymes to neutralize the acid. This allows pylori to find its way to the protective mucosa lining of the stomach, and its spiral shape facilitates the boring through the lining. Intake of aspirin or other antacids such as ibuprofen, naproxen induce ulcer formation by interfering with formation of prostaglandins, the chemicals that help the mucosal lining resist caustic acid damage. They irritate gastric mucosa and cause bleeding, erosion, and ulceration, especially with prolonged or excessive use. The NSAIDs group of drug is so named to distinguish them from the corticosteroids, synthetic variants of the natural adrenal hormones. The NSAIDs includes a dozen anti-inflammatory drugs. The basic symptoms of peptic ulcers are increased gastric tone and painful hunger, contractions when the stomach is empty. In a duodenal ulcer, the amount and concentration of hydrochloric acid are increased. In a gastric ulcer, the amount and concentration of HCl may be abnormal. Nutritional deficiencies are evident in low plasma protein level, anemia, and loss of weight. Hemorrhage may be the first sign in some patients. Diagnosis is based on clinical findings, radiographs, or visualization by fiber optic gastroscopy. The primary role of medical management for peptic ulcer disease is control of pylori. Additional supportive goals are to alleviate symptoms, promoting healing, prevent recurrence, and prevent the complications. In addition to general traditional measures, the rapidly expanding knowledge base and development of a number of new drugs have increased the physicians' available management tools. Adequate rest, relaxation, and sleep have long been a foundation for general care of peptic ulcer disease to enhance the body's natural healing process. Positive stress coping and relaxation skills, which help patients deal with personal psychosocial stressors, can be learned and practiced. Simple encouragement to talk about anxieties, anger, and frustrations helps to make patients feel better. And as soon as they are able, Appropriate physical activity helps work out tensions. Habits that contribute to ulcer development, such as smoking, should be eliminated. Common drugs such as aspirin and NSAIDs should be avoided. Current pharmacological management of peptic ulcer disease includes a wider choice of drugs to control underlying physiologic causes and clinical symptoms, as well as to support healing. In various ways, five types of the drugs suppress gastric acid and peptic secretions, protect the mucosal tissues, buffer acid, and eliminate infection. Receptor antagonistics. These agents, commonly called blockers, are popular drugs for controlling the gastric acid secretion. They decrease HCl production by competing with histamine for receptor sites on parietal cells. Histamine attached to its specific cellular receptors on acid producing parietal cells of gastric mucosa and mediates secretion of HCl. The blocking action of these agents effectively control acid and pepsin because inactive pepsinogen requires acid for activation. The four drugs in this classification have now been reclassified for OTC purchased. Another is PPIs. This new class of drugs, more potent than blockers, also suppress gastric acid by a different action. Prostaglandin analog misoprostol can be used with antacids to prevent the ulcer. This class of medication should not be used by the pregnant women. Long-term use of PPIs may lead to the hypomagnesemia, and it is recommended that serum magnesium level should be monitored. And other is mucosal protectors. Drugs of this type act as cytoprotective agents by helping the stomach heal itself. They produce a gel-like suspension that binds to the ulcer base and covers it and surrounding normal mucosal tissues to protect involved tissues from harm while it heals. This drug also forms complexes with pepsin that inactivates pepsin. Another one is the antacids. These well-known substances counteract and neutralize activity. They are safe and inexpensive to use. Two main types are magnesium aluminium compounds. Another one is aluminum hydroxide. Last one is antibiotics. Drugs of these types are used to control the biliary infection associated with the peptic ulcer disease. Treatment using one or two antibiotics, such as amoxicillin, pharmacologic therapy, is the treatment of choice for peptic ulcer disease. Diet plays a significant role in the treatment when compared with pharmacological regimes. Dietary recommendations are formed from individual tolerance and should be considered supplemental to pharmacologic therapy. Diet to decrease the gastric acid secretion or increase the time it takes to heal ulcer. Individuals with peptic ulcer disease should be encouraged to eat a healthy diet from foods they enjoy. Journal nutritional therapeutic recommendations include emphasizing a balanced, nutritious diet, limit the foods and seasoning, and encourage the avoidance of lifestyle habits known to increase acid secretions, inhibit the healing, or both. Caffeine, black pepper, chocolates, food that are irritating or not well tolerated, eating less than 2 hours before bedtime. Sound nutritional management plays an important support role in total medical care of persons with peptic ulcer disease. The individual must be the focus of treatment. The patient is not an ulcer. He or she is a person with an ulcer. The course of the disease is conditioned by the individuality of the patient and life situation. The presence of the ulcer affects the patient's life and quality of life. In the long run, a wide range of foods attractive to the eye, the taste, and regular unhurried eating habits provide the best course of actions. Drugs and nutrients shares the related characteristics in the body. They are most often absorbed from the same sites in the intestine. Both can alter physiologic processes and both can be toxic in high doses. Drugs used to treat the heartburn, gastroesophageal reflux disease, and peptic ulcer disease are commonly used. Many are available without prescription, which includes antacids and alginates. Antacids may have an effect on absorption of the vitamins and iron. Antacids should be taken at least 2 hours before or after iron preparations. The effect of aluminum containing antacids may be decreased by high protein meals. Prolonged antacids use, along with excessive consumptions of calcium, may cause high calcium level and result in serious metabolic disease. Antacids may impair folate absorption, which may increase the risk of neural tube defects and congenital abnormalities of the heart. Other is the H2 receptor antagonists react with many drugs, including the caffeine and alcohol. Blockers may impair the iron absorption through effects on the pH of the digestive tract and also impair the absorption of selenium. Vitamin B12 from food is impaired by blockers, but absorption of vitamin B12 supplements is not affected. Proton pump inhibitors may hinder the absorption of iron products, lessening their effectiveness. Proton pump inhibitors may also impair the absorption of selenium. Vitamin B12 from food is impaired by proton pump inhibitors, but absorption of vitamin B12 supplement is not effective.